Good afternoon, ladies and gentlemen. Welcome to our afternoon session. I hope you were able to relax during the lunch break. So we've got a very exciting afternoon program. To kick off this afternoon session was supposed to be Dr. Mukucha, but unfortunately he's got an emergency. So Dr. Emily Mukucha will present on his behalf. Dr. Mukucha is a senior registrar in obstetrics and gynecology, working at Paranath Hospital. She completed the MBCHB degree in 2012, and she's just completed the Masters of Medicine, Obstetrics and Gynecology. She's under the mentorship of the oncology team, working under Prof. Chirenje and Dr. Mukucha. She's going to present a case of severe endometriosis, a journey to a live birth. Dr. Mukucha, over to you.
Thank you very much, Dr. Matsire, for that quite humbling welcome. And I would like to thank you everyone for joining this meeting and for allowing me this time to share the case with you. This case was managed by my seniors in the private sector, and I'm just going to present it to you. I believe some of them are on this platform, so maybe at some point they would want to discuss a little bit further about it. So this is quite an interesting case and on the medical field, but it was quite a depressive experience for this patient. As you are going to see, as I'm going to be discussing the case with you, titled A Case of Severe Endometriosis, Journey to a Live Birth. So at the present moment, this patient is now 38 years old and she now has a baby, and she's still married and living with her family. And okay, the HIV status was for the clinical purposes that we are going to discuss about. So the journey of this patient started in way beyond 2014, but she presented to the panel of gynecologists who are here around 2014 when she was about 31 years old. So she presented with an interesting presentation for not the initial time, but to this current 2014 presentation. She was complaining of cyclical abdominal distension, which she reported that it occurred for about 10 months. And she also reported that this abdominal distension would seemingly resolve in between that, and then it would reappear on the next cycles, and it was increasing in size. Then she also had associated abdominal discomfort, and this was also associated with a history of primary subfertility. So on inquiring further into her history, this patient had been seen several times by physicians prior to coming to gynecologists at this moment in time, where she was being investigated for ascites. She had had multiple ascitic tests, which were inconclusive, and also prior to this, she had been seen by another gynecologist who had investigated her for subfertility, and it was deemed unexplained subfertility. So in this presentation back in 2014, which is like 7 years ago, with this initial presentation, an abdominal and pelvis ultrasound scan, CT and MRI scan of the abdomen were ordered. And this showed gross ascites, small bilateral pleural effusions, and uterine fibroids. Blood workout was only significant for the anemic picture of 8.8 and an elevated ESR and CRP. So the patient was, he had been, the patient has been referred with when the physicians had thought that she probably had an ovarian malignancy. So tumor markers were done and they were negative, and an autoimmune screen was done and it was negative, and the couple had also been tested for HIV and they were negative. So at this point in time, the decision to do a diagnostic laparoscopy was made, and they proceeded with that. All right, so on examination, the patient was noted to have the abdominal distension in keeping with the history with clinical evidence of ascites, and they proceeded to do a diagnostic laparoscopy. So during the procedure, they noted that the patient had chocolate fluid in the abdomen and pelvis, and they drained about 2,500 mils. She also had endometrial deposits on viscera and the parietal peritoneal surfaces. And also noted that the fallopian tubes were not okay anatomically. The right was mated and the left was stuck to the left fundal fibrate. They also noted that the patient had a sigmoid, the sigmoid colon was stuck to the posterior part of the uterine surface, and both ovaries could not be visualized. So they attempted adhesiolysis, but tissues were noted to be wet and friable, so the procedure was abandoned. And post-procedure, they done biopsies and they sent the biopsies for histology. The results came out and showed endometriosis, confirming the clinical and the intra-op findings of the diagnostic lab. So the patient's main concern as a couple was fertility issues and the control of pain. So the patient wanted to be managed in a way that she would be able to conceive. So with a working diagnosis of primary subfertility and stage 4 endometriosis, which was quite actually debilitating in a case, the patient was started on Visan, and she was referred for minimum invasive gynecology in an attempt that maybe they would also resect the endometriotic lesions. And the future plan of IVF was discussed with the patient, and she was quite agreeable for that. So in 2016, which was like 18 months later after this initial diagnostic laparoscopy, the patient managed to see the referral point for the minimal invasive gynecology. So the gynae who saw it then noted the above history and also reported that at that point the patient had improved a little bit it improved for some time on Vicen, and it now came back with associated dysmenorrhea and heavy menstrual bleeding. And she said that the dysmenorrhea was reported to be quite severe. So the patient's main concern still remained the issue of trying to conceive despite all these things that were happening to her. So an ultrasound scan was ordered and done, and it showed uterine fibroids with the largest measuring 6 centimeters, and one was reported to be indenting the endometrium. So as planned, the gynae who saw her proceeded to do another operative laparoscopy with an aim of trying to do endometrial resection, endometriotic lesion resection. So during the procedure, the report was that they drained hemoperitoneum, and there was also extensive pelvic adhesiolysis, which was done during the laparoscopic procedure. And there was also laparoscopic resection of endometriotic nodules, which were in the pouch of the in the closely adherent to the rectum. They also proceeded to do laparoscopic myomectomy of 4 large fibroids, and the fallopian tubes were also diseased. They had bilateral hydrosalpinx, and a decision to proceed and do bilateral salpingectomy was also made, and the procedure was done. And this patient was then commenced on Leucrin post-procedure. So histology of all the samples that were taken during this procedure came back, and it confirmed the endometriosis, the uterine fibroids, and the tubes were reported to be inflamed, engorged, and also confirming the hydrosalpinx. So during this time, while this procedure was being done, as the patient was being managed severe stage 4 endometriosis, the gynecologist was also in communication with an IVF team as they were planning to later on refer the patient for IVF. So the patient was adequately counseled post-operatively about the journey of her going on for IVF, and she agreed. And she also agreed that she would continue taking Leucrin until she managed to book an appointment with an IVF specialist. They had opted to have the IVF done in South Africa. So from this time, the patient went away and came back 2 years later in 2017. They came back a year later, which was in 2017. And this was now 2 years from the initial laparoscopic procedure that was done. So she now came back complaining of cyclic symptoms of chest pain and right-sided backache. And she reported that the chest pain was also radiating to the shoulders on a cyclical basis. So a CT scan of the chest and a CT IVU was also ordered on and done. So the CT scan of the chest now confirmed extrapelvic endometriosis. It showed lesions which were suspicious of an endometrioma related to the right-sided pleura, and there was also a moderate right-sided pleural effusion. And then the CT-IVU also reported extensive endometriosis in the pelvis, leading to stricturing of the distal left ureter and moderate left-sided hydronephrosis and hydroureter. So of note, I could have forgot to mention it on the operative laparoscopy that she had. The surgeons themselves also noted that the ureters were also, the left-sided ureter seemingly seemed to be involved, like there was stricturing, but there was no procedure done in that point. So a decision based on the above CT scan and CT IVU was made to consult and involve the urologist and the cardiothoracic surgeon. So this was done. The cardiothoracic surgeon proceeded to do a thoracotomy on this patient. After he had noted all the history and done his necessary investigations, he planned and managed to successfully do a thoracotomy. And then the result was that there was endometriosis resection from the right hemidiaphragm, plus drainage of 1.2 liters from the pleural cavity of bloody fluid. And then the urologist also noted the CT-IVU and proceeded to do a JG stent in the left ureter for the left-sided hydronephrosis that had been reported. This patient, the struggle continued as if she had not suffered enough. She came again complaining of hematochezia, and a decision was made to refer the patient to a general surgeon for assessment. So the general surgeon assessed her and managed to do a colonoscopy. The surgeon himself reported that there was an impression of an endometriotic lesion in the colon, and the pictures actually showed a lesion that almost suggested that I could have just managed to upload them. So he did histology biopsies from this lesion, and then the histology came back showing normal rectal mucosa. The team at that moment in time were not quite convinced that it could have been that, but they proceeded and reviewed the histology and thought it was still normal rectal mucosa. So the surgeon referred the patient to the gynecologist, where she was to be further assessed and sent for IVF. Because at this time, the patient, all she wanted was to have a baby. The main concern was to conceive. So she was trying to have the specialist tailor-make a management in a way that she would be able to conceive eventually. So in 2019, which was about 5 years from an initial visit in 2014 to the first gynecologist, and then 4 years from the time that she had the laparoscopic resection of endometriotic lesions, the patient managed to go to South Africa for IVF. She had transfer of 2 embryos, and then one of them was successful, and she was referred back to the obstetrician with a confirmed intrauterine pregnancy at 6 weeks 1 day. Then she was commenced on uterogestine and extrapose, which she took for up to 10 weeks. around the first trimester, the patient was counseled about the necessary diagnostic tests that she needed for a baby, including antenatal diagnostic for chromosomal abnormalities. And together as a couple, they refused to have this screening test done. They opted to just continue with the pregnancy, which was respected by the obstetrician and gynecologist, and the pregnancy continued. So, as I mentioned, this patient really struggled through a process of endometriosis, and as if it was not only enough of all the problems that she had with the stage 4 during this pregnancy, also she was reported to have developed a shortened cervix with slight funneling at the internal os. So a sacklage was inserted, and a repeat ultrasound scan at 22 weeks showed that the cervix had now had a cervical length of 26 millimeter, and the patient was reassured and counseled about continuing a pregnancy at this time. So at an estimated gestational age of 28 to 1 weeks, this patient developed PPROM. She was admitted at a hospital for the PPROM, and she then eventually had an emergency cesarean section at 28 weeks and 1 day. They delivered a live but preterm baby who had a very low birth weight of 1,175 grams, but the ABGA was good. It was 8 to 9 on 10, and the baby was admitted in NICU. So eventually she managed to hold the baby after this, this very long history of debilitating endometriosis with a very poor quality of lifestyle, as she suffered through so many stages, all the classical stages of endometriosis that we seem to read in the books. She went through most of them up until she managed to hold a baby and take the baby home. So this is just a picture summary of what we have just presented of this case, with the initial journey starting somewhere before 2014 with primary subfertility, which was deemed unexplained. She had managed for ascites by several physicians, and the results were also noted to be inconclusive. 2014, diagnostic laparoscopy was done, and hemoperitoneum was drained, and biopsies were taken, which also confirmed that the patient had endometriosis. So a journey with the diagnosis of endometriosis then began. 2016, she went through laparoscopy again, had endometriosis resection, bilateral salpingectomy for hydrosalpinx, and also had myomectomy for multiple uterine fibroids, with the largest, which was about 6 centimeters. The journey continued. In 2017, she had catamenial the symptoms, extrapelvic endometriosis, which involved a thorax, and then she had resection of thoracic endometriosis. She also had unilateral hydronephrosis with hydroureter, which required for her to have a JG stent insertion by the urologist. Then she managed to go for IVF in 2019, some years after she started the journey. IVF was successful, but unfortunately, again, in the same pregnancy, she had cervical insufficiency, needed a cervical sacklage. As if it was not enough, she developed PPROM at 28 weeks in the same year and was delivered as an emergency cesarean section, a preterm delivery. But however, she managed to eventually celebrate in 2019 when she went home with a baby girl. Thank you all.
Thank you very much, Emily. Very exciting case. Thank you to the team who managed this patient. We've got about 2 minutes for questions. Can you please have questions? You can either raise your hand or just unmute and ask your question. Maybe while people are still coming up with their questions, I just want to ask a few questions. Firstly, I think you said she started seeking treatment at the age of 31, meaning she eventually had IVF around the age of 36. I think that was about 5 years later. So I just wanted to know whether she actually used their own eggs or they use donor eggs. That's the first question. And then the other question is she got Lucrine for a very long time. Did she have any side effects from the hypoestrogenic effects? And of course, surprisingly, it appeared the disease process remained progressive while she was getting the generator agonist. Is there anyone who can answer that? I don't know if any of the teams managing clinicians are on the platform.
For the eggs, as I gathered, the two embryos. Oh, okay. Maybe Dr. Good or Dr. Jojo can respond to that. Thank you.
Dr. Guja?
So she used their own eggs.
Oh, okay.
And also the Visan, she wasn't using it continuously. I think there was a lot of defaulting treatment, and then she would kind of like have recurrence of the symptoms.
What about the Lucrine? I thought she got Lucrine for a very long time.
Unfortunately, when she got that, she wasn't now under my care. She was under the care of someone else.
Okay. Thank you very much. We can have one more question.
Yes. Can I find out? Can I find out whether this woman has been lost to follow up from the time she celebrated a baby, or we are still continuing to assist her, perhaps a second celebration? Thank you.
This woman, Prof, hasn't been lost to follow up. I think she, after her delivery, she has had a few issues with her stent, which was giving her some pain. The stent has been removed, but she hasn't given an indication. It was replaced rather. She hasn't been given an indication that she would like to try for another baby, but she hasn't been lost to follow up. I think the issue that probably wanted to discuss was because she has left ureteric involvement with a stent that has been there for quite some time. So my feeling is that she would need to have maybe a MDT kind of surgery and try and sort out the ureteric issue so that she doesn't keep the stent for a very long time. But she hasn't been lost to follow up.
Okay, thank you. Prof, you answered?
Yes, thank you very much.
Okay. Dr. Majangara, can you start sharing your screen before I introduce you to the audience? You can stop sharing. Okay, thanks.
Hello.
Hello, Dr. Vuma, you want to ask a quick question? Please go ahead.
Yeah, just a comment. Because I think right from the beginning, this patient, I think with the initial surgery, I think when you do it, you should prepare to do it correctly. This patient should have had an MRI scan from the beginning to go to diagnose this ascites. Then also the surgery, initial surgery, I think you should have also maybe had a look under the diaphragm to look for that. So either the MRI would have picked up that diaphragmatic endometriosis. And I still feel that obviously the ureteric thing, they should have had a ureterolysis, either with or without excision, because obviously the endometriosis is compressing from outside. So stenting does not solve the problem. You need to relieve the pressure from outside. So she needs obviously a proper uterolysis, a laparoscopic uterolysis. She doesn't. I don't think she would need to have the stent in permanently. And so basically, from what was presented in the morning, I think the wake up initially was thinking that maybe that could have averted some of the surgery, because with each passing surgery, it becomes more difficult to do the surgery because of scar tissue. So like what Dr. Mukucha is trying to say, that I mean, maybe she should have been presented to the multidisciplinary team earlier, and all the necessary pathology, because I'm not sure whether there was any bowel endometriosis that was picked up or was never looked for. So I still feel that maybe it could be actually managed differently with all the people involved, because once there was a ascites, you know that it's just a severe form of endometriosis. Thank you.
Okay, thank you, Dr. Buma, for your comment. And before both or any of the managing people respond, there's also a question from Dr. Marel who's saying, is she on any hormonal therapy currently? While he's responding, can you also please allow Dr. Majangara to share a presentation? Do you have any response to the comment, Dr. Mukucha, or any of the managing gynecologists? So I think the point taken, but there's a question whether you see on any form of hormonal control currently. Does anyone know?
And